Hi, welcome to this video on palpation and accessory movements for assessment. I'm Dr. Chee-Wee and I will be here to explore with you about this topic. Before we begin, let's have a look at the learning objectives for this video and this week's learning. At the end of this week, you should have a realistic and critical understanding of palpation and accessory movement and their roles in clinical assessment. You'll also be able to critically evaluate the multiple factors that may influence the validity and reliability of these techniques in your own clinical assessment, as well as in clinical practice more generally. Before we start, it is important for you to note that the palpation and accessory movements we're referring to here is used in clinical assessment. That is to find out what is the patient's problem. We of course know that similar touch-based techniques can also be used for therapeutic purposes. However, that isn't our focus here. At this point, let me first tell you a story. I'm a father of 2 children. As with every parent will know, one of the joys of having children when they're very young is the constant lookout for the little ones falling ill. This is usually because of some infection they've caught from the nursery or even at home. The very first sign of children falling really ill is when they look listless and unable to enjoy playtime. When I see this, my very first instinct is to use the back of my hand to feel their forehead and necks. I'm of course trying to see if my children are having a temperature. If the fever is high, I'm quite sure that my child is experiencing some sort of infection and will take appropriate steps next. However, if they're having just a mild temperature, then my hand is a rather blunt tool and won't be able to feel the slight fever. At this point, I'll usually have a thermometer ready to confirm my suspicion that my child has the fever. As the thermometer is able to provide a more objective reading, I can make sure that my concerns are real and that any medicine I give my child is necessary. So what is the clinical relevance of this to what we're trying to look at today? Well, my attempts at using the back of my hand to detect the fever in my child is usually only useful when the fever is high enough. When it's borderline or for some other reasons, my hand is a pretty crude tool to detect a fever. To put it into a psychometric language that we've learned so far, my hand has a moderate sensitivity and low specificity for detecting a fever. As for its responsivity to change, it's probably quite poor as well. But the thing is, we use it anyway as a first rough investigation. Our palpation skills and feel of joint movements as diagnostic tools are similarly blunt instruments. As we will see later, they are only good enough for clinical assessments and should always be used with other clinical assessment techniques. So, how good are our palpation skills and feel for joint movements? We'll explore that question together in the rest of this video. So keep these questions at the back of your minds as we look at some studies relating to this topic. As a starting point, let's look at 3 studies done on static spinal palpation. This involves the location of spinal vertebral structures on patients. Usually, 2 to 3 clinicians are compared for these types of studies. I've only chosen 3 convenient studies to look at in this video as representative of other studies. There are more studies published that looked at this topic with various variations of it. So if you're interested, you can search for reviews down on them. Now, coming back to the static spinal palpation studies, we'll first look at intra-rater reliability of this technique. The 3 studies here are arranged according to the spinal segment being investigated. As you can see from the kappa index, which is an index of reliability for categorical data, the intra-rater reliability is quite variable, ranging from low all the way up to excellent. It always seems to suggest that the intra-rater reliability increases as we move down the spine. Now, this is interesting because there are other studies that suggest the opposite is true. Now, there is that is any form of reliability gets worse for palpation as we move down the spine. By the way, The clinicians in most of the studies here are chiropractors with experience levels of more than 3 years. So I want you now to keep these reliability figures in mind whilst we move on to look at the inter-rater reliability. Okay, we now have the figures for the inter-rater reliability for the exact 3 same studies. Now have a look at the reliability figures. Are these better or worse than the intra-rater reliability statistics we had previously? Unsurprisingly, the inter-rater reliability figures are worse than the intra-rater reliability. Again, we observe that the reliability figures gets better as we move down the spine. And again, I'm telling you that there are studies which suggest the opposite. Another thing you can see here is that the reliability figures are extremely wide and broad, which means that there are probably many factors that can bias inter-rater reliability. So, we've looked at the spinal regions in terms of the reliability of palpation. But what about the other regions of the body? Are palpation techniques more or less reliable than those used in these other areas? Now, here is a summary of the results from a review by Hutchinson 2013. It looked at 10 different clinical tests for the diagnosis of Achilles tendinopathy used clinically. Specific to our topic here, palpation of the Achilles tendon to elicit pain was looked at in this particular review. What it found was that palpation was rather good at diagnosing Achilles tendinopathy. Now, looking at the psychometric statistics, we have a sensitivity of 94% and a specificity of 73%. This is actually an incredible result. Furthermore, the review also showed that intra-rater and inter-rater reliability are quite good as well. Another example of palpation used in clinical assessment is the Ottawa ankle rules. This is a set of rules that helps to rule in the possibility of fractures when someone has an ankle sprain, thus indicating the need for further x-rays to confirm the presence of a fracture. Now for this, the rule sets a series of criteria that the clinicians can use to determine if an x-ray is indicated. One of the criteria is the palpation of bone tenderness at 4 specific areas in the ankle region. Now these areas are the 6 centimeters area from at either tips of the lateral or medial malleoli, at the navicular, the base of the 5th metatarsal. In addition, if the patient isn't able to weight bear both immediately and in the emergency department, this is also an indication for x-rays to rule out fractures. So how good is the Ottawa ankle rules, which is essentially a combined use of patient complaint, clinical manual, palpation, and functional testing? Well, it is actually quite good, but only for ruling in a fracture. The rules has a sensitivity of 99.6%. Now this is again incredible. For the result of a positive test, 99.6% of the patients actually have an ankle fracture. Nevertheless, the rules isn't so good for using to rule out ankle fractures. The specificity of the rule is only about 47.9%. The clinical and economic implications of this finding and this particular test is that when a services uses the Ottawa ankle rule for screening, it will likely reduce the amount of unnecessary x-rays being performed, yet at the same time achieve a high detection rate. This means better clinical assessments and also lower costs for both clinical service and patient. In addition, this relieves the workload of the radiography department and is a win for all concerned. So what can we conclude from this? We can say that palpation, when used appropriately for specific regions of the body, it can actually be rather useful. The caveat is that we shouldn't just rely purely on palpation to make our diagnosis. As a rule of good practice, we should always confirm our clinical hypotheses about a patient's condition through the combined use of various tests. As we've seen, the reliability of palpation can be quite variable. That is, it can actually have quite large range of values depending on the study and context. So why is that so? And what are the factors that contribute to this variability? There are probably multiple factors that may have contributed to the variability. Here, we're going to have a brief look at two of these factors: the experience level of the clinician and the consistency of the forces used during joint mobilizations and soft tissue palpation. Let's have a look at the clinician's experience level first. In 2003, Billis and their colleagues performed a study that did include 3 different clinical experience levels: students, clinicians, and therapists who perform manual therapy as their main specialty. They've also chosen 3 spinal segments for determining their reliability of palpation. If you're interested in the details of the study, the reference is at the end of this video. Jumping straight into the reliability findings, what they found was that the more experienced clinicians had better reliability than the students for both intra-rater and inter-rater reliability. This is probably not so surprising, given that experience can be an important factor in terms of reliability. Nevertheless, there are also a minority of studies that have looked at this indirectly and found clinician experience level to be a non-influencing factor for reliability. But in general, clinician experience does affect reliability. As an aside, if you remember previously, we mentioned about the increasing reliability as the level of the spinal segment gets lower. In this study by Billis, the opposite occurred. The lumbar level had the worst reliability compared to the cervical area. Okay, the next factor we'll look at is the amount of force the clinician is applying to the joint. Gorgos and colleagues performed a review of the studies that investigated this issue. They found that, in general, the consistency of forces exerted by the same person is generally better than if we were to compare the consistency between persons. This again is probably not too surprising, but it does provide us with a hint as to why palpation and joint mobilization may be as good as we want it to be when used during clinical assessments. So, we've looked at some of the Clinimetrics of the use of palpation and joint mobilization for clinical assessments, and it's okay, but not great. Where does this leave us? One could argue that since it's so inconsistent, it may be better to not use it, since it might adversely mislead us into making a wrong diagnosis. Now, this argument is hard on the assumption that we're only ever going to use palpation and joint mobilizations as the prime diagnostic tool. In reality, we'll be combining several tools to come to that diagnostic decision. So based on that realization, perhaps a better way to frame this is to acknowledge the limitations of palpation and that these tools should be used in combination with other tools as well as used within the context of the patients. For example, in terms of the rather good sensitivity for the Ottawa ankle rules. So this is the end of the video, and I hope you've learned something useful. If you're interested in the studies that I mentioned in my video, the references are shown here. This is Chee-Wee, and as always, thank you for watching.